Welcome everyone. This is Dr. Sharad Jaitly from New York, your cardiologist on your favorite website, MuniMeterHealth.com, which is on our social media channels being shown across the world, primarily to educate you on the human heart and its illnesses. Welcome again for watching, learning, and sharing. I thank you for the same. Also, I thank you for your enthusiastic support that you've thus far shown, primarily to foster my interest and my passion to educate people freely to all across the world. Thank you again for being on MuniMeterHealth.com. Without any further ado, I'd like to delve into the subject matter. The subject being today, what is PDA? Patent ductus arteriosus. It's a congenital form of cyanotic heart disease, specifically so in the adults by the time it manifests. However, it does start off by the normal conduit which fails to occlude between the aorta and the pulmonary arch, if you will. So let's draw what is the aorta here. And now as the fetus is growing, the non-functioning fluid-filled pulmonary, the lungs and the fetus, they do not receive the circulation, and from the right ventricle straight it goes via the ductus arteriosus, which supposedly is patent, so which is connecting to the descending part, the proximal part of the descending aorta, if you will. So I'm going to draw the pulmonary artery now, as you see here. Let's see if it works. Yes, it does. And so essentially it is this conduit which is now which serves in the fetus so that the circulation straight from the right ventricle, because remember the fetus's right ventricle is right here, and that's connecting directly into the aorta. So as a result, as the child is growing now after birth, normally this closes off. And if this closes off, so the right ventricle has no choice but to send the blood to the left atrium, and initially, of course, send them to the lungs for oxygenation, and then later on it returns back to the left atrium. So that having said, let's see what happens when you have this scenario happening in this fashion. You have the aorta, and you have the ductus arteriosus connecting here, if you will, and then you have your pulmonary artery arch, and this becomes your pulmonary artery right there. So now this portion of the ductus arteriosus, which fails to obliterate, normally it takes about a day or two post delivery, or once the child is born, on day 1 or day 2 it normally closes off. Now if it stays open, the left to right shunt will begin. Why? Because the aortic pressures are higher in the newborn, and obviously these pressures will drive oxygenated blood, remember oxygen rich blood which is in the aorta flowing, into the pulmonary artery. So it is a cyanotic condition initially. Now over a period of time, what will happen is the right ventricle will start to send more blood, and then eventually coming back into the left atrium, and then more blood will go via the aorta. So there is a left ventricular hypertrophy that will start to set in first. So an LVH will develop first, then next would be the RVH, because sooner or later the right ventricular hypertrophy occurs, and then as a result a biventricular hypertrophy will develop, and then subsequently a pulmonary arterial hypertension will develop in that order. So by the time the pulmonary arterial hypertension has occurred, obviously at that point the fatality mortality rate is very high, and things become irreversible regardless, even if you want to repair the PDA, because the treatment for PDA is just close it. Basically, as early as you can diagnose it, you have to just close it, because this way the left to right shunt does not reverse to right to left and result into pulmonary hypertension, which later on becomes irreversible. So having said that, let's see what the ECG will essentially show. ECG, of course, will show the LVH pattern first, later on biventricular hypertrophy, and some element of P pulmonale by means of pulmonary arterial hypertension. Clinically, the clinical features would be very clear. Here there will be a machinary type of murmur. Why? Because it's going to be more like a continuous murmur, like a vroom, 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 something like that. So there will be a murmur that will be continuously transmitted via the aorta into the pulmonary artery from high pressure zone to the low pressure zone, and it persists throughout systole and diastole, because remember, it's not rising from the valves which we normally see. So it's a machinary type of murmur. Diagnostic tests wise, echo is clearly showing a diagnostic feature where the color Doppler will define this, what you may call the left to right shunt here, if you will, that's traveling here in this direction initially, and later on, if it becomes the right to left shunt also, the color Doppler will reveal. But then at the same time, just remember that once the right to left shunt develops, then you have to look for the pulmonary arterial hypertension and their pressures, etc. A caveat here is, remember, if you have to send this patient for repair, if on echo you find a pressure gradient more than 50 millimeters mercury, if it is present in the shunt, that means across the pulmonary artery into the aorta, then or rather aorta to pulmonary artery, you will see that becomes a diagnostic point and a referral point for repair. And how do you repair it? Essentially, the repair is done by closing this patent ductus with a metallic coil, or just causing an obstruction here by any device that's normally placed in. It's a percutaneous procedure. The adolescent is home the same day, and so essentially a PDA is closed, or closure of the PDA is done. Now, if the PDA goes undetected or for some reason was not closed when the child was growing, at that point the patient will start to develop cyanosis, because now you have obviously a right to left shunt now existing. So once you have a right to left shunt existing, you will start to see cyanosis. Then there will be a clubbing manifestation, and the clubbing manifestation occurs very typical in that there is more distal clubbing. That means more in the lower extremities, because here this is where the deoxygenated blood is mostly going, whereas the upper extremities, including the brachiocephalix, is still getting the oxygenated blood. This is where the mixing is occurring. So right to left shunt occurs right towards the proximal end of the descending aorta. So all the lower extremities will have more clubbing, more cyanosis. So there is a differential cyanosis that's present, quote unquote, in the PDA in the young adult. So that's a distinguishing feature. Machinary murmur I've already talked to you about, the diagnostic features on the echo and Dopplers. Now, what makes a high-risk PDA, for instance? Why does PDA develop in some individuals and not in others? Well, it's a very, very simple thing, because one, it's highly prevalent in premature births. The ratio is about 8 in 1,000, as opposed to normal births where the ratio could be only 1 to 2 per 1,000. So you can see the difference. That's almost like 4 to 8-fold between premature and normal births. German measles or rubella, for instance, if that is contracted within the pregnancy period, that becomes an etiology as well. And then there are some genetic components to it which we still do not know clearly, but there is some genetics involved in PDA where the ductus arteriosus fails to close. So this was, in a nutshell, a small video vignette on PDA. Hope you enjoyed the discussion here, and of course there might be a question or two on the boards for the cardiology fellows or residents, and on the American boards or national boards if they are taking the medical students, etc. So, of course, you're welcome to really suggest anything, comment, and of course, if you like the discussion, don't forget to press the like button. I again remind you, because that's one way I will know and get your feedback that you're enjoying what I'm discussing here with you. And once again, I thank you for watching MuniMeterHealth.com. So long, this is Dr. Jaitly.